session. I want us to start our next session with our current Commonwealth Fund Fellow presentations. Dr. Laurie Zephyrin will be our moderator as well as our commentator at the end for these presentations. She most recently joined the Commonwealth Fund as Vice President for Healthcare Delivery System Reform, where she leads the Vulnerable Population Portfolio. She has extensive experience in terms of delivery system innovation and healthcare models. Prior to coming to the Commonwealth Fund, she was the first National Director of Reproductive Health Program at the Department of Veterans Affairs and has held other strategic appointments within that department. She is not new to the Boston area in that she was actually did part of her training here in the combined program, Brigham and Women's and Massachusetts General Hospital. So it was fun watching her last night, see her old friends and make those kinds of connections again. She was an assistant professor at Columbia. Followed by that, she was an assistant professor of OBGYN at NYU School of Medicine. Please welcome Dr. Zephyrin.
Thank you, Dr. Reed. I'm very excited today to just see and hear all the presentations. I just want to say congratulations to all of you. You should really pat yourself on the back. I don't think we spend enough time in our lives doing that, so please do that today and just take in just the breadth and depth of what you've accomplished this year and the community that you're joining and the work that you'll continue to do moving forward. You're all amazing in your own right, and I'm really honored to be with all of you today. And I love seeing the representation across specialties here. I've always been, early on in my career, sort of a unicorn in spaces, and sort of, one of the few OBGYNs at the time as an RWJ clinical scholar, and the only one as a White House Fellow. And so it's nice to sort of see sort of this spreading across specialties, because I think that voice is very important and you have a lot to contribute. So it's truly significant. And it may not be a straightforward path, being the only one or few in your specialty entering this work, but your voices are needed at the table. And they're valuable, and your perspectives are needed as well. And I love the representation across mental health, pediatrics, radiation oncology, orthopedic surgery, pathology. I mean, it all affects vulnerable populations, so I'm really excited about that. So let's get started. Dr. Jennifer Parker is our first presenter, and Dr. Parker is a radiation oncologist, and she early in her career, she already has conducted breast and cervical cancer trials and clinical research, and presented at national meetings. She's been an active member of the Student National Medical Association for over a decade, serving at the local, regional, and national levels, also serving as national vice president. She's also served as president of the Northwestern McGaw Underrepresented Residents and Fellows Forum. She's committed to serving the needs of racial and ethnic minorities, and her goal through the policy implementation process is to coordinate integrated care across hospital systems and ultimately improve healthcare delivery, so all very much needed. Dr. Parker earned her PhD in chemical and systems biology from the Medical Scientist Training Program in 2011, and received her medical degree from 2012 from both Stanford University School of Medicine, and most recently was chief resident in radiation oncology at Northwestern Memorial Hospital. I'm going to read all of your bios because it makes me feel happy. I know it may be embarrassing you, and some of you may already know it, but I just have to honor all the achievements that you've done. So Dr. Parker, I'm really excited to hear your talk about creation of a chat box tool for oncology patient management.
Good morning, everyone. My practicum project focused on the creation of a chatbot tool for oncology patient management. Today's talk is going to go over the definition of a chatbot, research describing access to digital health solutions for minorities, background on the company I worked for called Wellframe, what machine learning is, how Google Dialogflow works, a couple examples of the chatbots I built, and finally, next steps and future directions. So what is a chatbot? A chatbot is a computer program designed to stimulate conversation with human users. In December of 2018, the Commonwealth Fund, along with the Pew Research Center, came out with an article called "The Time Is Now: The Case for Digital Health Innovation for the Poor and Underserved." In this article, they discussed that venture capitalists in health systems will spend greater than $7 billion in digital health solutions within the next year. However, few of these resources are accessible to people with low incomes due to regulations, as well as lack of insight about low-income Americans' access to technology. The Commonwealth Fund and the Pew Research Center conducted interviews with low-income patients in DC to determine use by these communities. Their findings were as follows. They were able to demonstrate that mobile ownership is not a barrier to digital health innovation among low-income people. 95% actually owned a smartphone, could text, and maintained at least 3G internet access. There was no consistent access to technology, however, for those who were chronically homeless or greater than 80 years of age. Most at that time were using technology to understand symptoms. However, low-income Americans would use it, if available, for scheduling, immediate access to healthcare providers, such as online chat or telemedicine visit, and as well as for medical decision support or symptom triage. So the company I worked for is called Wellframe. Wellframe is a software technology company, and they make patient-facing mobile technology to improve chronic disease management. Some of the diseases they have worked on are diabetes, hypertension, and congestive heart failure. Currently, approximately 10 million people are covered by Wellframe. Their patients are enrolled in commercial insurance or private insurance, Medicare, as well as Medicaid. Wellframe is free to all patients who are enrolled, and they've been able to demonstrate through their mobile technology decreased care utilization as well as cost for chronic disease patients. Prior to me interning with the company, they had not entered the oncologic care space, and given my experience as an oncologist, they were open to my idea of creating a chatbot for oncology patient management. So now I'm going to talk a little bit about what machine learning is and how machine learning works. So machine learning is a type of artificial intelligence. It uses this process to make better predictions based upon data and answers that you know to be true. So as you can see in the picture, for machine learning, you have data and you have answers or outcomes that you know are true based upon that data, and from there, the computer is able to create rules. This is in contrast to classical programming, where you have data and you apply rules that have already been created to come up with the answers or the outcomes. And so machine learning is able to work by building a model through training, validation, and testing. So for the training component, they have a training set, which is the known data and answers that you know to be true based upon that data. The data is then used to build a model, and the more data that you have, the better the model is trained. From there, you're able to validate the model, which is to determine how well the model performs. And depending upon whether or not you're happy with the validation, you can alter the model's parameters and retrain it. This is finally followed by testing, which is where you take a set of unknown data that you do not have the answers to test it against the model you created to see if you can get a valid performance measure. Some of the challenges of machine learning are that large data sets are necessary to develop these technologies, and often minority groups are less represented in these data sets. Health challenges for minorities are less obvious to data science teams because they're usually not representative of these populations. There has been greater emphasis as a result of machine learning on personalized recommendations and not on the social and structural determinants of health. It also has the potential to distract governments from responsibility for citizens' health, given the focus on personalization or individualization. And finally, health organizations such as safety net hospitals or public health organizations face cost constraints, preventing them to actually develop artificial intelligence technologies. Some of the benefits of machine learning, however, are that it has the potential to improve efficiency and effectiveness of processes in health organizations by being able to predict diagnoses, risk, and treatment outcomes. It can even help address patient illiteracy and numeracy, as machine learning can help fill in gaps in a patient's intent or what they're trying to get from the chatbot. You can also create models that are culturally sensitive and can be trained to recognize these type of phrases. And machine learning can improve over time with the increasing amounts of data that are being processed. So now I'm going to talk about what Google Dialogflow is. So Google Dialogflow is a computer program that's actually based upon machine learning, and this is what I use to build my chatbots. So Google Dialogflow uses intent, entities, and fulfillment to complete actions. And so if you look at the top part of the diagram, you have a user who then has a device, which is typically a computer or a cell phone, that they can use to query the bot or talk to the bot. And from there, the bot is able to figure out what the person's intent is. So for example, if you wanted to book a flight, the chatbot is able to know that the person intends to book a flight. From there, it extracts code, which is also known as entities. These entities are things that the bot needs to be able to answer the person's intent. So for a flight, you may need to know the date, time, where you're coming from, where you're going, the airline you want to take, etc. From there, it can go out to an external API or a database. An external API is like a third-party application, such as a flight calendar. And once all this information is gathered, it's able to fulfill the person's request, and this becomes actionable data that they can then output back to the user. So now we're going to get into some of the examples that I created and how I went about the process of creating those examples. So my methods were to develop patient personas based upon my interaction with thousands of oncology patients over the last several years. I then identified specific problems that these patients may experience, such as pain points, which are also called pain points in startup world. So you have scheduling, radiation dermatitis, excuse me, pain management, nausea and vomiting, as well as polypharmacy. Based upon these pain points, I created algorithms to address each of those, and then I coded the bolded algorithms into Google Dialogflow to create the chatbot. So this is just an example of one of the algorithms I created for scheduling. So scheduling is the intent of the patient, and they have to have these different entities, which are doctor, time, day, duration, and reason for visit, that the bot extracts from the patient's conversation. That then goes out to a database, which would house the doctor's appointment calendar. And if the user is satisfied with the appointment they have, they will sign off. If not, the user will ask a new question. And Google Dialogflow works through Google Assistant, which many of you all may already use. You can find it on your cell phone, you can find it on a tablet, computer, a watch, and even in your car. So this was the first test chatbot that I made. It's a scheduling test chatbot. It's called Dr. Fix Me. That was the name I came up with for it. The bot asked what the patient's name is. In this case, I just used my own name. It asked, how can I help you? I then said, hey, I need an appointment. It said, which doctor would you like to see? I said, Dr. Parker. It said, great, what time would you like to see Dr. Parker? I said, 2 o'clock. It then went on to ask me what day and my reason for the visit. And once that was fulfilled, which is what would happen by going out and checking the physician's calendar, asked me if I needed help with anything else, and I said no, and said great, and signed off. So that interaction was complete. I then did one for radiation dermatitis. Every radiation oncology patient at some point has radiation dermatitis, and oftentimes they're dealing with the side effects at home. And because radiation is a daily procedure, it can also be a big burden on nursing and physician staff. And so this is a way to try to prevent some of those unnecessary interactions and have the patient be able to manage their side effects at home. So in this instance, the patient's name is Janice, and Janice complained that her breast was red and itchy. And so the bot queried her about what type of treatment she was getting. In this case, she was getting radiation. And then since she was getting radiation, it asked what she was using on her skin. She responded, Eucerin. Said, that's great, you're using Eucerin. What else are you using for the itchiness? The patient said nothing. And so as a result, the bot told her, that's not good. You should be using that. In addition to the moisturizer, it told her when to use it and how to use it. And since the patient's request was fulfilled, the bot was able to sign off from that conversation. So next steps and future directions will include refining some of the current chatbot conversations I've come up with, which are the scheduling, radiation, dermatitis, and pain management. We're going to code the remaining algorithms into Google Dialogflow, which will be the nausea and vomiting and polypharmacy. After that, I want to test all of the algorithms in Spanish. Google Dialogflow has the capability for you to code in any language that you want. After that, I'm going to perform pilot studies with patient stakeholders in order for me to gather data across different patient populations about access to care, care delivery efficiency, cost, as well as patient and physician experiences, which is what WellFrame has done with their mobile-facing platforms for their current chronic disease management areas. And finally, I will present this to digital stakeholders, which potentially sponsor implementation to patients, such as payers and hospitals. This is how WellFrame has been able to provide their technology free to all patients through sponsorship. So I would like to thank my preceptor, Dr. Trishan Panch, who is the CMO and co-founder of WellFrame, as well as the other WellFrame employees, Dr. Joan Reed, the Harvard Diversity, Inclusion, and Community Partnership Office and staff, Harvard Medical School, Harvard T.H. Chan School of Public Health, the Commonwealth Fund, and of course, my co-fellows for a great experience this past year. Thank you. Yeah, sure.
Does anyone have any questions? Oh, are there mics?
No, it's okay. I'll stand by the mic.
Thank you very much. This is very, very exciting. My name is Qian Ji Huang. I'm with Asian Women for Health. And we just recently started a online support group for Chinese breast cancers, Chinese women living with breast cancer. So my question is so how can we integrate your app with like other apps like WeChat and, and do you have a capacity to gauge or assess the conversation trends? Like in our support group, there are certain topics that come up, and can you, like for example, reconstructions, or can you do that kind of thing?
Yeah, so WellFrame, for their current platform, they are able to integrate with other applications. So same would be able to be done with the chatbot. And the cool thing about Google Dialogflow chatbots is that you can record the conversations the patients are having with the bot. So when they actually go back to see their provider, the provider could get a printout of what they've been discussing at home to make sure all of those things are addressed during their appointment, because a lot of times patients do not bring up all of their concerns, especially if they feel like the bot was able to handle them. So it'll allow for more comprehensive care because you're getting a real idea of what patients are concerned about before they're actually coming in for their appointments.
Can you hear me? Okay.
Yeah.
Great. Congratulations. That was a great talk. And I think it's a generational thing, but I detest all these bots that are out there now, mainly because they don't understand nuance and complexity. I know your examples were like, I want an appointment Tuesday, 2 p.m. But in reality, you say Monday through Thursday, sometime between 6 and 5. And can the bots do that now, or are you cognizant that this is a problem and then you're hoping to make them evolve?
Yeah, so one of the things with Google Dialogflow is, as I talked about, kind of refining the conversations, you can train it with whatever data that you want to have included. And so part of being, underrepresented in this field is that I can bring in some of the cultural nuances that a lot of the people who do this work do not think about. And you can actually put in training phrases into the bot based upon what you think people will ask. And it's able to, the more practice and the more data it has, the better it is at recognizing those statements and outputting the type of answers you want. So you can definitely make more complicated conversations. Like my preceptor right now is making one for patients who want to call into the bot and just ask about their deductible. And so the bot will have to be able to go and query their specific deductible, their plan, to figure out how much they have left. And he's been able to do that and allow them to talk about different procedures they want done and find out what the actual price for that will be. So it's definitely possible. You just have to have people who are cognizant of those things to actually build that into the models.
Well done. How do we guard against under triage of certain concerns by patients?
Yeah, so one of the things that once we take it further that we would actually build into there is kind of a disclaimer that this does not substitute for all care that you would get. And depending upon the questions that are asked, there's a fail-safe mechanism you can put in place for the bot to then say, this is beyond what I can help you with. You need to either call your doctor or go to urgent care or go to the ER.
Thank you. That was fantastic. Thank you so much. What an amazing presentation. I have a bunch of questions. So next up, Dr. Shayna Lipa is an orthopedic surgeon. She completed her residency in orthopedic surgery at Harvard Combined Residency Program here at Brigham and MGH. And she's also vice chair for MGH Center for Diversity and Inclusion and Fellow Committee. She is dedicated to the improvement of health and healthcare disparities and really focused on advocacy in the space of orthopedic surgery, which is critically needed. And she aspires to improve musculoskeletal health and healthcare disparities that women, African Americans, and Hispanic face with regard to severe arthritis and functional limitations, which we see in the literature. She also had longstanding involvement in SNMA, serving as the chapter president at UCSF, and has done a number of other leadership work. And she was also a recipient of the National Medical Fellowship Community Service Learning Program. She graduated with her medical degree with distinction at UCSF, and also in medical school, she participated in the visiting clerkship program. So another amazing program that Dr. Reed and her team leads. So I'm really excited to hear about your talk about, does the implementation of Medicare accountable care organizations reduce healthcare disparities among patients treated for spinal fractures?
Thank you, and good morning. I did just receive a promotion. I do want to say that I'm actually still in residency, but I will take any promotion that is available. I am in between my 4th and 5th year of residency and doing this Commonwealth Fund Fellowship. So I will go back and finish residency here next year and then be on my way to fellowship, another one. So my project looked at the impact of Medicare accountable care organizations on disparities in spine fracture care. The host organization that I worked with was the Brigham and Women's Hospital Center for Surgery and Public Health, also known as the CSPH. It is a center that is at the intersection of research and public health. It is one of the first centers to actually focus on this in the country and as a model for the country. So I was very happy to be able to work with this organization. The goals of the center are: 1, to provide direction for patients, physicians, and policymakers, and 2, to improve quality and access to care for all. Background on my project: as we know, there are healthcare disparities in all fields, and even in orthopedic surgery, despite my colleagues not liking to focus on it or talk about it. The documented disparities in orthopedic surgery are related to access to surgical care and also higher rates of perioperative complications. The majority of studies that have been done have looked at the pre-healthcare reform period. So those specifically have focused on traditional fee-for-service Medicare, and which we know traditional fee-for-service Medicare has not done a great job at moving the needle on healthcare disparities. So what I wanted to look at was a healthcare reform initiative that came after the Affordable Care Act, specifically Accountable Care Organizations, or ACOs. And ACOs have been proposed as an initiative that would not only reduce costs and improve the quality of care, but also possibly lead to the reductions in healthcare disparities. And so I will get into that a little bit. I'll highlight what ACOs are on the next few slides and how they could lead to reductions in healthcare disparities. This is a definition from the Centers for Medicare and Medicaid, and it specifically says that ACOs are groups of doctors, hospitals, and other healthcare providers who come together to voluntarily give coordinated, high-quality care to their Medicare patients. And I want to highlight coordinated in this definition because that is one of the key words and actually ways that we think that Medicare ACOs will help to improve disparities. Just to compare traditional fee-for-service Medicare to Medicare ACOs, in traditional fee-for-service Medicare, doctors and hospitals are generally paid for each test and procedure, which have driven up the cost of care in the United States, and it also rewards providers for doing more. Instead of looking at quality, which on the contrast on the right side of the screen, you see that Medicare ACOs create saving incentives by offering bonuses when providers keep costs down and meet quality benchmarks. And if you look on the Centers for Medicare and Medicaid website, there are a lot of quality benchmarks that you can see. They have updated ones for 2019. And some of those benchmarks include getting patients timely care, like appointments. There is also specifically a quality benchmark for coordination of care. So this is why, instead of having fragmentation of care through providing different tests and procedures and getting paid that way, Medicare ACOs specifically are focused on coordination and integration of care, which are key for reducing fragmentation. Because we know that fragmentation in the healthcare system actually can lead to failed handoffs and lapses in treatment, and this specifically affects our low-income patients and our racial and ethnic minorities. And the hope for Medicare ACOs being able to improve healthcare disparities in an integrated type system came from research that was done in colorectal, well, specifically for surgery, the research that was done in colorectal cancer that showed that a model of an integrated healthcare system through coordination, as I mentioned, was able to improve disparities between Black and white patients in treatment for colorectal cancer. So my motivation for this study specifically is that there haven't been any studies that have showed or looked at national changes in healthcare disparities in the setting of spine fracture cares and ACOs. And why am I specifically interested in spine? I'm going into spine surgery. I actually recently matched into fellowship. So I wanted to focus on spine, and I wanted to, in that context and all the contexts mentioned above, I wanted to examine the impact of Medicare ACO formation on post-treatment outcomes and surgical rates for white and non-white beneficiaries treated for spinal fractures. Just the next two slides will just briefly give an overview of spine fractures. It's very basic, but I just wanted to make sure you all are on the same point with me when I talk about the details of the study. Basically, when someone has a spine fracture, they can present to a provider in many different ways. They can go to the emergency department, urgent care, their primary care provider, and sometimes, depending on the severity of the fracture, they can go from the primary care provider to ED and urgent care. So that's a longitudinal move. But then they get referred to a surgeon, a spine surgeon specifically, and both orthopedic surgery and neurosurgery do spine, so they can either see one of us. And then from that point, we determine treatment options, which basically are non-operative versus operative. And then I'll just go into brief detail about what an operative spine fracture care would look like. So if someone, this is just an example in the lumbar spine, and they're not actually fractures in this picture, but just an example of the surgery. So if someone had a fracture that were to compress any of the neural elements we would then do and cause a deficit. We would then do a spinal decompression, which you can see on the left side, which is basically removing some parts of the back of the spine in order to allow more room for the neural elements to move around because of the compression from the fracture. And then if patients had a fracture that was compressing the neural elements but also was unstable, then we would do a decompression and a fusion. So now that we've gotten that out of the way, to get back to the point of the study, the outcomes that we looked at, we wanted to examine the impact of Medicare ACOs on whites and non-white patients treated for spinal fractures. Our primary outcome looked at post-treatment outcomes. One, we looked at in-hospital mortality. We looked at 90-day readmissions, 90-day complications. Some examples of the 90-day complications include surgical site infections, more systemic infections such as sepsis, and then possibility of having a blood clot. And then secondarily, we looked at the rate of surgical intervention. In order to identify patients, we used National Medicare Fee-for-Service claims from 2009 to 2014. And just to mention, the 2009 to 2011 period was the pre-healthcare reform period, and 2012 to 2014 was post-healthcare reform. We used the claims data to identify socio-demographic factors and also to identify the factors that we needed for our primary and secondary outcomes. A multivariate logistic regression analysis was used to evaluate and analyze our data. And just to mention, whites treated in non-ACOs between 2009 to 2011, which is the pre-reform period, were the referent group in this analysis. Key findings for our study: in terms of surgical utilization, there were no racial and ethnic minority differences in the use of surgical fixation for spine fractures treated in accountable care organizations. When we looked at our perioperative outcomes in terms of complications, there was a disparity in the development of complications for non-whites in non-accountable care organizations that we did not see in accountable care organizations. And then looking at another perioperative outcome, when we looked at readmission rates, we saw that non-whites in ACOs in the pre-reform period had a disparity in readmission rates that was then eliminated after ACOs were formed. In conclusion, our study reinforces the idea that ACOs could improve healthcare disparities among minority patients through standardization of care and integrated care delivery pathways. ACOs can help to eliminate some of the variations in clinical care that we've previously seen in the healthcare system. There's also potential that as ACOs become more familiar with integration and streamlined delivery services, that further improvements could be realized. Limitations of this study. Given that our study data ended in 2014, this study only looks at the early period of ACOs. So there could be a more discernible impact in the present and future. And also to go along with that, because we looked at the early study period of ACOs, individual and racial ethnic minority groups had to be treated as non-white because there was not enough, the numbers were actually too small to analyze with any statistical power if you broke down into certain racial and ethnic minority groups. Additionally, another limitation in the study is that ACOs were considered as a single group. And we know throughout the literature that there are invariably high and low performers within this category. And lastly, because we relied on claims data, we're not able to categorize the extent of spinal fractures and also why patients were considered for surgery or not. Going along with that, further research does need to be done, and specifically our data ended in 2014, and when data becomes available that is more present, we can actually look at how accountable care organizations have performed given that they have had time to integrate, be more integrated, and actually streamline these pathways. And then another set of research related to the to the limitations that I mentioned is that we haven't been able to look at these on a granular level as in terms of high and low performing Medicare ACOs, and I think that can also be accomplished. Next steps, this body of work has been submitted for publication. But in addition to that, in terms of policy, we want to work with our partner, which is Movement is Life. And they are an organization that is focused on the improvement of musculoskeletal health and healthcare disparities. And working with them, we want to work on policy initiatives at their national caucus meeting, which happens every November. And so just to talk about Movement is Life for 1 second, they're an organization that aims to improve musculoskeletal health and healthcare disparities through research and dissemination on musculoskeletal care, which I think this body of work does, but then also they want to look at solutions that address disparities. And so that's what we'll work with them on. One example of a policy recommendation that we would make is that right now Centers for Medicare and Medicaid don't have an incentive for improving disparities. So like I mentioned earlier in my talk, there are quality initiatives that look at other things, such as coordination of care, whether a patient's getting an appointment, and various other factors. But there's not specifically a benchmark that's focused on disparities. So we're hoping that maybe coordination and integration is going to help the improvement of disparities, which we see from this study, and there have been a few others that's shown that it has, but I don't think we can just rely on that. I think we need to push for a specific quality benchmark that says, are you improving disparities in your field? And for me specifically, it would be musculoskeletal health care disparities, but I think that we can also, everyone else in their field can also advocate for that as well. I just want to take time to acknowledge everyone that's been integral in my work this year. Dr. Andrew Schoenfeld is my mentor. He is at the Center for Surgery and Public Health. And Dr. Mitch Harris is the chair of MGH and has been supportive of me throughout the year. The next two people, Daniel and Justin, were part of the study. And I want to thank Dr. Joan Reed, Dr. Alden Landry, the Commonwealth Fund Fellowship in Minority Health Policy, and my Commonwealth Fund Fellows for 2018-2019 for being a support system this year. Thank you.
Let me take one question.
Anytime you get a surgeon at the podium, it's a good start. It's been too long.
I knew
And
you were
so
coming up here. I knew you were coming.
And so I'm so proud of the work, and the presentation was outstanding. I think you get at this in your limitations, though. Once you create an ACO, the real question is, do you operate on all comers, or do you begin the cherry picking process of who actually gets surgery? Because now you're entering to the risk phase for the organization of who will do well and who will not, and what the costs are then downstream to that organization. Is there any way, as we go forward in the work that you've laid out, to really begin to look at who is actually getting to the operating room table and who is not? Or does this data just simply reflect that the ACOs are picking winners and losers successfully? Thank you so much for the presentation.
Yeah, thank you. I think that's a good question. I will say that during this year, I did another study that looked not specifically between white and non-white patients, but just looked at the utilization of spine fracture care overall. And we wanted to do that because we wanted to see whether in the pre-reform and post-reform period, if there was a difference in surgical utilization, because spine fracture care should be a non-discretionary surgery. Basically, if someone needs a surgery for spine care, they should get it regardless if they're in an ACO that's looking at quality and trying to save costs, or whether they're in a traditional fee-for-service system where people are getting rewarded for doing a procedure. So in that study, it actually showed that there were no difference in the rates of surgical utilization. So patients in the pre-reform period had the same rate of surgical utilization as they did in the post-reform period, regardless if you were an ACO or a non-ACO. So which was a plus for ACOs, because you don't want to be withholding care. That's one of the fears with ACOs, as it was with HMOs back in the 1980s and 90s. And so that was one of the fears initiating this policy reform initiative. But we think that specifically in our field, we were able to show that there was no difference in the utilization of surgical care. Now, as far as breaking it down into racial and ethnic minorities, I think that is something we probably try to tease out a little bit here, but is specifically on a granular level, who is making it to the operating room and who is not. No, we don't know that yet.
Thank you. And I'm going to move it along just for time purposes. I know we started a little bit late, so I will keep my comments short so that you guys have all the time to talk. So Dr. Nusheen Amenadine is a pediatrician, and she's an assistant professor in the Division of Community and Pediatric Adolescent Medicine at the Mayo Clinic. And also, she's very passionate about advocating for underserved and immigrant populations who we all know face significant barriers to health care. She participated in a vaccine education outreach program, which helped improve vaccination rates, improve vaccination rates in the community as well. And those efforts have helped halt the spread of measles. She's also part of a social media campaign, hashtag Keep Kids Covered. So, Dr. Menadine received her medical degree in 2002 and her MPH degree from the University of Kansas Medical Center, and completed her residency in pediatrics and adolescent medicine at Mayo School of Graduate Education at the Mayo Clinic. So thank you, and she'll talk with us about the public charge, a threat to public health for immigrant families.
Good afternoon, everyone. I hear the caffeine in your veins. That's a good sign. Thank you so much, Dr. Zephyrin. I just wanted to say one of the reasons that I chose to take part in this particular project is because I do work with a large immigrant population in Rochester, Minnesota, and also my family actually immigrated to the United States from India a little over 40 years ago. So thank you for being here. I wanted to start out with giving you a definition of what public charge is and why this is important at this particular point in time. Essentially, a public charge is an individual in the United States who is primarily dependent on the government for subsistence. These are people who are generally unable to contribute financially to the system for whatever reason. They have previously been defined as people who have to use cash benefits, which include Social Security income or temporary assistance for needy families. The reason that this is important for immigrants in particular is because that immigrants who apply to get visas in the United States or green cards, legal permanent residency, or citizenship have to go through an application process. And using certain types of public benefits, particularly cash benefits, can be a negative factor for them and can affect their application. So what is important here is that we need a little bit of context for public charge. It's not really a new concept. In fact, as early as the 1600s, right here in Massachusetts, the Pilgrims, who were among the earliest immigrants to this country, actually created a law to keep out, quote, undesirables. I will let the irony sink in for just a moment. But the idea was that they wanted to control who came into this country. And that concept has been consistent in one form or another, but the current definition of public charge was really set around the mid-1990s with welfare reform. And that was at the time when, through this comprehensive package, the US government decided that legal permanent immigrants to the United States would have to have a 5-year waiting period before they would be eligible for certain services like Medicaid, food stamps, housing vouchers, and that undocumented immigrants would not be allowed to access certain benefits, although that gets a little bit complicated because from state to state, there is a little bit of leeway. So that's a little bit of background. In response to concerns from immigrant families, INS, Immigration Natural Services, created field guidance a couple of years after welfare reform to reassure immigrant communities that if they did in fact access non-cash benefits once they were eligible, that would not be held against them in their applications for citizenship if they decided to go further with that. But that's what's been challenged more recently. And so that brings us to October of 2018, where the Department of Homeland Security proposed an expansion of the existing public charge rule. Oops. Essentially, last fall, after about a year of leaked documents, the Department of Homeland Security finally issued their formal proposal. What this proposal would do would expand the definition of public charge, which again could be used to deny petitions for visas, legal permanent residency, or citizenship for immigrants. But what happened now is that it wasn't just confined to cash benefits. It would now include non-cash benefits. So immigrants who have used Medicaid, SNAP, or food stamps, or housing vouchers would potentially have that as a negative factor in their application, which is a change even from the welfare reform of a little over 20 years ago. What's important about the public charge rule is that it's not something that would have to go through Congress. It's not a bill that would have to become a law, because it's already a law that's on the books. It would not require an executive order from the president. All that would need to happen is that Department of Homeland Security, in putting forth this proposal, would have to finalize it, because it's a reinterpretation of an existing law. And I guess the public component of this is that since it doesn't have to go through any of those usual checks and balances, they would have to go through a 60-day comment period where anyone in the United States, regardless of their immigrant or non-immigrant status, can comment. And so from October to December of 2018, we had this 60-day period open during which anyone was able to comment on this particular rule. And that's exactly where our intervention came in, and I did my practicum with a medical legal group here in Boston. What was interesting is that during these 60 days, there was unprecedented advocacy from a number of different sectors. Child health organizations, the American Academy of Pediatrics was very vocal about this. Immigrant health organizations, coalitions, the National Immigrant Law Center, and many social justice organizations were very vocal. And what that ultimately resulted in was, I'm going to go back for a second, over 200,000 individual comments from people in the United States, primarily negative, primarily saying this is a law that would hurt immigrant families, immigrant children, which I thought was great. But I'm sure I'm giving away my bias there, sorry. But we also, as a part of this effort, had formal statements from organizations like the American Academy of Pediatrics and the organization that I worked with. So again, I was fortunate to work with Justin Lowe, my preceptor, who's the legal director at Health Law Advocates. It's one of only 4 medical legal partnerships in the United States, right here in Boston. My job as the intern was to examine the chilling effect or the indirect effects of this proposed expansion of public charge. And then I submitted my report to Justin and his team. They incorporated those findings into their analysis and ultimately submitted their official statement to the Department of Homeland Security. And in looking at possible effects of the expansion, I did 3 different things. I did a literature review. I looked at what would affect immigrant families. I looked at data from the Kaiser Family Foundation and other immigrant organizations that estimated what effect this rule expansion might have. I also used the Manat tool, and I have a screenshot up there. This is actually really cool because it uses data from the American Community Survey, which looked at immigrant populations that accessed these services from 2014 to 2016. If you go to the website, you can actually look at your area. It breaks it down by metropolitan areas, state by state. It looks at race and ethnicity. It looks at essentially who would be affected, which again is incredibly helpful. You get the national view, but you also get the view of how your specific community would be affected by proposed expansion. And I also looked at historical precedent, what happened after welfare reform when these expansions were made. And what we found after looking at this is that about 24 million people in the US, immigrants, would be affected, about a third of which would be children. And to put this into context, we're actually talking about legal immigrants here who are working families oftentimes who pay taxes but who happen to be low income and who qualify, therefore, for a number of these services. And by extension, it would also include immigrant families of mixed status where maybe they have US-born citizen children, but the parents, one or both, are immigrants. So in looking at what would actually happen and in examining this chilling effect or the indirect effects, we realized that anecdotally, physicians across the country and other organizations were reporting that families were disenrolling voluntarily from services that were technically exempt from the public charge designation. What's interesting about this is, some of you may know, Women, Infants, and Children is a supplemental program which in some of the early leaked versions of the public charge draft was included as something that would be included. But because of public outcry for those leaked drafts, it was actually removed from the formal analysis. But there was enough fear created among immigrant families that they were already disenrolling from WIC and from other services. We also found, especially with the help of the Manat tool using the American Community Survey data, that this would disproportionately affect non-wealthy immigrants and immigrants of color. So unless you're white and wealthy, you would really be at a disadvantage as a result of this pending rule expansion. We also noted that in the wake of welfare reform in the mid-90s, there were unexpected effects. Refugees and asylees were actually exempt from being labeled public charges, but there was actually up to 54% voluntary disenrollment from a number of those programs 20-some years ago. And so we have to acknowledge, again, that there is a significant amount of fear there. And really, what this boils down to is that if there's fear of enrolling in needed services that help bridge economic gaps for families, for children, at the risk of losing your legal status and the ability to stay in the United States, immigrants have already been shown to be avoiding accessing these preventive services that they are legally entitled to. This can further exacerbate financial security in the home, food insecurity, housing insecurity, and ultimately children are less likely to thrive as a result of that because these are proven anti-poverty programs that have been successful. So that puts us to right now. We're in May 2019. The Department of Homeland Security is still reviewing these over 200,000 public comments. Thank you to everyone who commented on that. Appreciate your input. And really, we're in a bit of a state of limbo. There are three possible outcomes after DHS completes their review. Number one is that they can finalize the rule as they originally proposed. Number two is they can potentially amend the rule based on these 200,000 comments and the formal analyses by organizations, or they can sort of forget it. The rule remains unchanged and there's no expansion. I will say that's not likely to happen. I got an interesting email late last night with an update on public charge, but I'll save that for the question period. So next steps for us as a medical community, public health community, research community, and frankly just as residents and citizens of the United States, this is an issue that most likely will not go away. So one thing we can do is contact our legislators, let them know how this will affect our patients on a personal level and on a community level. We can work with partners on advocacy for this particular issue. And we can also seek out alternative resources for our families if they are trying to avoid federal programs that would otherwise help them. And I just want to say thank you to everyone. None of this would be possible without the help of the Office of Diversity and Inclusion and Community Partnership, Dr. Reed, Jackie, Ying, Christine, Dr. Landry, everyone who has been a part of that. We so appreciate it. The Commonwealth Fund's generosity in funding our fellowship, Justin from Health Law Advocates, everyone at the Kennedy School of Government, and most especially my fellow fellows who almost never let me take pictures of them. So this one was actually a rare moment. Thank you, guys.
Great work. We'll take one question. The email.
Oh, okay. Yeah, all right. So again, the email late last night, I was like, oh, great. there's more to come. So there's another leaked either addendum to the rule or another, component of public charge that potentially people who are here, legal immigrants, can now be deported for using one or more public services. So again, not official yet, but it's there. And in preparation for that and other challenges, organizations like the American Academy of Pediatrics are preparing amicus briefs to challenge this if it does go forward. So keep aware of it, and thank you again for everything.
Great. Thank you very much. That was amazing. So our next presenter, Chantel Herbert McGee. Did I do that? Did I say that correctly? Okay. So Dr. Herbert McGee is a cytopathologist and associate professor of pathology, previously at University of Central Florida College of Medicine, and she was the founding director of academic pathology at the Center for Interventional Endoscopy in Florida. And so really excited that you're here and presenting. I'm looking forward to hearing your work. She is well published, authored over 50 peer-reviewed publications, editorials, and white papers. She launched a foundation under the Scope Foundation, a 501c3, using microscopy and pathology to mitigate the socio-behavioral environmental factors associated with pancreatic cancer in underserved communities. And her calling to public health really dates back to her teen years in her hometown of New Orleans. So I'm really excited to hear more about your work, neighborhood segregation, access to buprenorphine for opioid use disorder in pregnant women in Camden County, New Jersey. So thank you.
Because of my strong interest in federal health policy, I had the pleasure of working at the Urban Institute, which is a policy research organization, also known as a think tank within Washington, D.C. At the Urban Institute, they have the Health Policy Center, which focuses on state and local initiatives to improve population health, in particular reviewing public policies. And so my research fell within the latter, looking at public policies that have recently been implemented in Camden County, New Jersey, and seeing how they impact the lives of individuals in the targeted area. So opioid dependence is a public health priority. It's actually a crisis. We have 2.1 million individuals who are currently opioid dependent, and in 2017, we had nearly 48,000 fatal overdoses. Buprenorphine is a novel new treatment modality that is preferred over methadone maintenance because it has a better safety profile. In particular, buprenorphine is a partial agonist, means that it doesn't completely bind to the receptor. Therefore, there is less abuse potential in comparison to methadone, which is a full agonist and completely binds to the receptor, so there is higher risk of abuse. Moreover, buprenorphine is significantly more expensive compared to methadone. Because of the differences in price, buprenorphine treatment is largely confined to predominantly affluent and white neighborhoods. There have been initiatives in order to increase access, particularly with Medicaid expansion. They covered buprenorphine. Unfortunately, a study in 2012 showed that only 10% of providers accept Medicaid to treat opioid dependence with buprenorphine. Additional barriers are health status, particularly pregnancy. We had many very important discussions yesterday about the impact of pregnancy when it comes to opioid use disorder and the high risk of fatality. In addition to that, it also causes low birth rate. Buprenorphine has been known or proven to decrease the likelihood of fatal overdose during pregnancy, decrease HIV transmission during pregnancy, and also decrease neonatal abstinence syndrome, meaning that babies who are born are less likely to express withdrawal symptoms. There are other barriers. There are other individual and social barriers and interactions between the two. So I'll just use criminal justice system. So imagine a person that has been recently released from an incarceration facility, and if they try to go to a clinical center, there may be implicit bias or stigmatization, which may be a barrier to access. In particular, we looked at New Jersey. New Jersey is a state that has been plagued by de facto segregation, meaning that segregation still persists. And looking at Camden County, Camden City, which is within Camden County, is one of the most segregated and dangerous places to live within the county. It's rife by financial bankruptcy, crime. There is high school attrition rates, and in general, there's just low opportunity within the area. There's been recent legislation passed in New Jersey in order to tackle the opioid crisis. Particularly in 2017, Governor Chris Christie signed the Senate Health Bill 3, which is specifically is supposed to tackle opioid usage in endemic high minority areas. Also, there was $1.5 million allocated to the Cooper Health System, which is in Camden City, in order to address neonatal abstinence syndrome within pregnant women. So the issues. Studies have not adequately assessed the location of providers with the buprenorphine waivers. So in order to prescribe buprenorphine, you have to have a waiver. And whether those providers are actually prescribing buprenorphine. The objective of the study was to determine the contributory role of the neighborhood attributes and neighborhood residential segregation patterns, meaning the social barriers to buprenorphine treatment access in pregnant women, which we identified as an individual barrier, particularly in Camden County. Now, while there are 3 phases of buprenorphine treatment, we will only focus on the maintenance phase, which is when you appropriately dosage the patient, and now they will be on consistent therapy indefinitely. We recognize that medicated assisted treatment is necessary, and it's akin to almost keeping a diabetic patient on insulin. So my methods, I did a robust, systematic review of the literature, both the white and the gray literature. I selected geographic areas and providers based upon residential demographics and the clustering patterns. I defined the call script, did survey validation, and did a fielded phone survey with the selected providers within those clustered areas. And then finally, I analyzed and summarized the findings from this study so we can have future health policy directives. So when it comes to the characteristics, we looked at zip codes and neighborhood characteristics, in particular using the 2010 U.S. Census, and wanting to know the percentage of individuals within a given area that were Hispanic, Black, or less than 2 times the poverty. We all have been told that zip codes are more important than genetic codes. And looking at that, we wanted to aggregate or cluster areas that had similar social characteristics based upon the zip code. Now, using Ward's model, which is a heuristic statistical model in order to cluster the different aggregates data, we ended up with 5 different clusterings. So you can see that there is low Black, low Hispanic, and low poverty, and then there are high areas of minorities and high poverties. And so we have 5 in order to make sure we have enough variance in power for the study. Now, SAMHSA is the organization that actually keeps a database of all providers with buprenorphine waivers, and using the database, we contacted providers within the high clustered areas. The survey, first we validated that they were actually the provider, their name, their location, and then we asked them, were they actually providing buprenorphine therapy? Were they accepting insurance? If so, New Jersey Family Care, which is akin to Medicaid, or private insurance, or just self-pay. We wanted to know the wait time. So were they currently accepting patients? And if so, how long did it take for them to come into the office? And then were they accepting pregnant patients? And if not, who were they referring those patients to? And finally, we looked at congruency. Previous studies have shown that patients have better outcome when there's patient-provider congruency in race and ethnicity. So our results, we had 103 providers located within the clustered areas. I was able to get survey participation with 73 providers. The 30 non-respondents, I called them up to 7 times before a boarding call unless they blocked my number, which some of them did. And actually, looking at the results, you can see that in areas that had high minority and high poverty, they were more likely to participate in the survey. And so individual participation ranged in these areas from 74 to 97%, whereas in areas that had low minority and low poverty, there was decreased participation between 25 and 44%. Now, I was very excited to see the number of providers that were actually prescribing. And initially, when we saw that 25 were prescribing in the endemic area, we were very excited because it's one of the initiatives of Governor Christie. Unfortunately, when looking at maintenance, we only saw 9. So what is this discrepancy? 16 providers were only doing induction. So imagine if a patient came to the ER, they had almost overdosed, and so they would not go back out and start using again. They would give them a dosage of buprenorphine to sort of stabilize them and diminish their craving, but it did not get them immediately into treatment or provide actual maintenance therapy. So our results, buprenorphine waivers were negatively associated with communities that were particularly high minority, high poverty. In addition, there was prolonged wait time. So as you saw, there were only 9 providers of the 38 that participated in the survey that were providing services. So therefore, you're going to have wait times. And these wait times were considered prolonged. It was anything over 2 weeks up to 4 months. Now, this is a map of Camden County, and so I've highlighted 2 areas. So Camden City, which we discussed, and then there's Cherry Hill. So green labels demarcate providers who are actually providing services. So Cherry Hill is a city where the median household income is about $80,000, and you can see all the providers in this area are actually prescribing. Whereas Camden County, Camden City actually has a median household income of $20,000. And even though you have so many providers with waivers, none of them are actually prescribing. And so in looking at pregnancy, access is diminished in areas that are high to moderate African American. And providers in areas that are more affluent only accept self-pay, which is somewhat predictable. So the limitations of this study, obvious the lack of total providers, and we realized that in low areas, one of the reasons that I had a lower participation in areas that had low poverty and low minority is because they had screening services. So someone would answer the phone and they would be the answering service, and they would not allow for me to speak to the provider in order to do a survey. There were also assumptions regarding ethnic and social backgrounds of people living within a given neighborhood. So if every patient in Camden City may not necessarily be poor or high poverty. That would be an ecological fallacy. There may be people who actually come for treatment outside the area and see that physician. This study did not access the burden and severity of other comorbidities in these patients. And then finally, using the U.S. Census from 2010, we recognize there may be neighborhood shifts in character, that have changed, and population shifts in those areas. So that may also be a limiting factor. In conclusion, the dissemination of new lower-risk opioid agonist treatment in Camden County is unequal. Buprenorphine treatment is disproportionately benefits those who are in predominantly white and affluent neighborhoods where they can self-pay. And because we have these types of disruptive innovations, right? So when you have cell phones, you think of Fitbit and say, oh, wow, this can make a difference in communities. When you have this type of disruptive innovation, it only benefits those who are able to get access to it. So it widens the gaps, it widens the chasms between 2 sectors of population, those who are affluent and predominantly white, and those who are minority and predominantly poor. So I would like to thank my preceptor at the Urban Institute, Lisa Lemons-Klope, and obviously the Commonwealth Fund, and all the members here at Harvard, Dr. Reed, Dr. Landry, and y'all know I love y'all. So, okay.
One question from the audience. Dr. Riley.
Hi, Pamela Riley with DC Medicaid. Thank you for that presentation. We're struggling with a lot of similar issues in DC, and I'm just wondering from your interviews, did you get any insight why providers that are waivered are not prescribing? Did you probe that at all?
Because I did. So there were a number of reasons. For some who were in the endemic areas, they just didn't have enough support, recognizing the complexity of those patients, whether they were recently released from prison, whether they were homeless. They were less likely to adhere to buprenorphine therapy and have the agency to be able to handle that. In addition to it, they also mentioned that that the Medicaid reimbursement is lower. And so if you have more complex patients, meaning that's going to require more time, you have to do your analysis, you have to discuss why they're still using opioids while they're taking the buprenorphine. And so it may prolong the actual office visit to like 1.5 hours rather than having a 20-minute office visit. And so because they don't have the infrastructure, now in regards to pregnant patients, some of it overlaps. They don't feel comfortable seeing pregnant women. They haven't been, they're not trained as an OBGYN. They may not know who the patient's OB doctor is. And so I think those are some of the factors with that. And so it's like, how do you address that?
Thank you.
Can we save it until the end? Can we save it until the end? Because we're going to have some time at the end. Thank you so much. I really want to hear that question, so please. Amazing presentation. Thank you all. And Dr. Daniel Gonzalez, thank you coming on up. You're going to talk about targeting behavioral health gaps among Latinas in Los Angeles County. Dr. Gonzalez is a psychiatrist, recently chief resident and clinical fellow at Cambridge Health Alliance here at Harvard Medical School. He's also a service leader in both Latino Mental Health Clinic and the Gender and Sexuality Clinic and Consultation Service at Cambridge Health Alliance as well. He's very accomplished in his work in research and advocacy and education, and he's very interested in improving the quality of behavioral health care and patient experience for LGBT communities, Latino populations, and his clinical interests really include the intersectionality between LGBT, Latino, mental health advocacy, and minority health policy and resilience-focused interventions and wellness prevention. He received his medical degree from Geisinger Commonwealth School of Medicine, and welcome. And congratulations. Really excited.
Thank you, Dr. Zephyrin, for that very kind introduction. And also, I'm very keenly aware that I am standing in between you and lunch and also Mallory's question. So I will try to be as efficient as possible in moving forward. Right? So I had the privilege of working with the Los Angeles County Department of Mental Health, both as a psychiatrist and as a Latino in Los Angeles County growing up. This was particularly meaningful, so this was an amazing opportunity, and I very much thank the organization and Dr. Reed for your leadership for this. So together, the Department of Mental Health and I, we sought to look at behavioral health inequity, specifically among Latino adult populations served by DMH. So we know that Latino communities show, they show similar susceptibility to mental health conditions as the general population. However, they experience inequities in both access to care and in the quality of treatment for very specific challenges and many issues, those including lack of insurance, medical mistrust, cultural and linguistic barriers, the list goes on. These challenges place Latino communities at risk for more severe and persistent forms of mental illness. So Latinos in Los Angeles County comprise about 50% of the population, and that is nearly 5 million individuals. So I want everyone to think about that as we move forward. So the Los Angeles County Department of Mental Health is very much committed to serving vulnerable communities, including Latino communities. They very much emphasize independence and personal recovery, and they have a strong emphasis also on the community integration and connectedness. Of course, we can all think about our own networks and our own communities and families and how much that values into our own wellness and resilience. The Los Angeles County Department of Mental Health is also the largest county department facility in the U.S. It serves about 250,000 patients annually, and it's directly responsible for about 75 program sites, many of which are affiliated with major academic teaching institutions such as UCLA. So these maps show the county of Los Angeles. The colors are actually show the 8 service areas that the Department of Mental Health helps facilitate and coordinate. On your right, you're going to see like these tiny blue dots, and those are actually about over 200 ambulatory care centers and acute service centers that the DMH really tries to coordinate across the 8 service areas. As you can see in South Los Angeles, there's a higher concentration of these clinics and sites, and within the past 10 years, given gentrification, housing instabilities, the cost of living increasing, a lot of Latino communities are actually moving upwards and northward. And so when you think about the lack of resources in those areas, and we were just talking about the barriers and challenges to access to care and the quality of treatment, I want you to think about that also playing into these inequities that are further increasing. So when meeting with leadership and with different folks at DMH, there was this huge emphasis on trying to really figure out how to best address these inequities. Of course, as much motivation and as positive and well-intentioned as we all are, we also notice that there are very strong, significant key challenges to be able to do so more effectively. At DMH, there is no centralized patient information database, and so when you're thinking about how to best use your resources, how to target your interventions, it's very unclear on how to do so, especially if we don't have much information about the patient demographics or their behavioral health needs. So my practicum project consisted of 3 main objectives. The first objective was to collect patient information regarding Latino adult patient population served by DMH specifically. Along with this information, just trying to get a better sense of what are some of the existing behavioral health inequities. The second objective was to meet with as many DMH representatives as I could possibly contact and organize these qualitative information interview-like settings to really get a sense as to what the challenges are and what are the current policies and interventions in place in LA County. And the third was to use both the patient information and the challenges described and try to really think about behavioral health initiatives that are going to make a big impact. And so reflecting first on the first objective, I collected so many surveys, documents, reports. I think it was over like 200 forms of documentation that were scattered among different service sites. And working with leadership and really trying to make collective statistics that would encompass the entire county was definitely a priority. Through this research, we found out that 50% of the patients actually identify as Latino. Over 25% of them mostly speak Spanish at home, and about 70% of folks are either obese or overweight. And so you can imagine that being in the behavioral health sphere, these characteristics are going to be very crucial in being able to facilitate the implementation of more informed and targeted interventions. So LA, the Department of Mental Health, they utilize a county health survey. It's called the LA County Health Surveys. And these are telephone-based systems. So basically, researchers call residents within LA County and they ask them a series of questions, and that's how they capture a lot of the information regarding behavioral health inequities. Through these surveys, they found that 6.4% of Latinos are currently experiencing active symptoms of depression, and that 13.9% are at risk for developing depression. Now, if you look at the next slide, this is going to break down the information on a more granular level. Specifically, if you look at Latino populations, there's a foreign-born and U.S.-born. I was overly ambitious and was really trying to encapsulate more communities, such as like LGBTQ or perhaps folks from certain income levels. But really organizing and consolidating this type of information is a huge challenge, especially having such a large county population. And we can see here around foreign-born, the 16.6%. Now that is a very significant number, and it really tells us how disproportionately at risk they are for developing major depression. Now, when we look at substance use specifically, the surveys also ask a host of questions regarding substance use, specifically around alcohol use, prescription drugs, and marijuana use. And we see that 19% of Latinos reported binge drinking in the past month, 7.7% reported misusing prescription drugs in the past year, while 9.5% reported marijuana use. again, I try to break down this information in as much granular detail as you could, using the LA County as like a reference point and really trying to figure out where these subgroups landed. And we see that with binge drinking and with the misuse of prescription drugs, they fall into higher rates, especially when compared to the LA County group. So now I'm going to focus on the qualitative information. And so what I did is I first constructed an interview guide that I was going to use as a standard measure to be able to use with as many DMH affiliates as possible. And so I contacted several sites, and 60% of the program sites that I contacted were agreeable with participating with me. And so I asked them multiple questions regarding their resources, what policies were sort of in place to help Latino communities specifically, and also looking at the challenges to serving Latino communities. So of these 60% of the program sites that I was able to contact, this actually consisted of 41 individuals. So what this means is I sat down with 41 individuals, asked them questions, and these interviews were structured, and they lasted about approximately 1 hour each. And these 41 individuals represented 6 program sites across LA County. So the information was ultimately broken down into 2 participant groups. The group 1 comprised of clinicians who worked on the ground floor, and so these were individuals who were either working with patients directly, either through clinical services or through education. Group 2 were individuals who were behavioral health experts, but they were more on the policy level, so they were in charge of implementing initiatives, working with programming. So when I used qualitative analysis, I coded and I looked for common themes across the groups. And among the group 1, looking at behavioral health experts and clinical providers, we saw that the lack of both behavioral health providers and support staff were definitely a main issue to being able to secure adequate access to care and treatment for Latino communities. And the second barrier being the concern for inadequate treatment of comorbid substance use and medical issues. When you look at group 2, you can tell that some of the themes that were popping up were more on systemic and global, capturing a larger scope of the interventions that they're trying to really implement and design. And they very much emphasize the lack of coordination and communication across clinical sites as being a main barrier to really providing adequate care. And the second being the fragmented care between primary care and behavioral health sites. So now I'm thinking about the third objective, and with leadership, we're trying to figure out where do we hone in and really implement some changes? Where can we make change in room? Because there's obviously a lot of need everywhere. So how do we prioritize this? Knowing the patient demographic information, but also figuring out what the barriers that were identified in the previous qualitative information. So with over 200 affiliated sites and clinics, you can tell that improving coordination and communication is definitely a priority within DMH. And one of those is trying to figure out, what are the tools, especially trying to incorporate technological advances. And shout out to Dr. Parker with her talk earlier today about how do we push this needle forward using the resources that we have in place. And of course, when we're thinking about interoperability, so across the 200 sites that DMH utilizes, very few service areas actually utilize the same EHR. So you can imagine if there's a patient that's floating from one service area to another one, it's like, how do providers communicate? So definitely the emphasis is going to be on improving the interoperability. Currently, the DMH, it does have a software program called Lanes, but it seems to have a lot of challenges as far as providing information from one service source to another. And then the second is really in this notion of integration of behavioral health into primary care settings. I know here in New England, there are a lot of different models of collaborative care, of co-location, of trying to figure out how to best optimize service providers. We know that there's a scarcity of not just behavioral health resources, but also providers themselves. And so how do we think about putting them into primary care settings and really emphasizing such things as like diet, nutrition, and exercise, knowing that a lot of these behavioral interventions, such as psychotropic medications, have a lot of secondary side effects, weight gain, metabolic syndrome, etc. So when we think about the broader implications of this work, I want to raise the question of, beyond LA, how is this information relevant? Why does it matter to all of us living in Boston? And so, I want to get this right. So Harvard-affiliated researchers Fernando Moreno Fernandez, Rosana Hernandez Nieto, and Marcus Gutierrez, they actually studied the Latino communities and how often they are spreading and how they are growing in frequency beyond the cities that we typically feel that Latinos are most highly concentrated. On this map, the darker red counties show the higher density of Latino populations. And so I think historically we think a lot about like California, Texas, Chicago as being these main hubs of Latino communities. But through their research, they actually discussed how between 2003 and 2014, Latino populations have more than doubled in 28 out of the 50 states. And so when you're thinking about these behavioral health implications as far as like looking at inequities and what interventions to really hone in on, you can say that it may have national implications. So again, when we leave and we're making these conversations, and I really liked Dr. Clark's mention earlier this morning about how we should all try to meet together, have coffee, really try to investigate having all of our different specialties and backgrounds about how do we collaborate and make these greater systemic changes. Of course, my focus is more on behavioral health and trying to implement, thank you, and trying to really hone in on the gap, but how do we work collaboratively to really improve our wellness, not just physically, but also behaviorally. Thank you very much for listening and appreciate it.
Congratulations, fantastic research and presentation. The question I have is that Latino is a large, varied category, and for fear that you will fall into the trap that we who work in Asian American health do, that we are not one monolith, does DMH make any effort to distinguish what the subcategories of Latino are? I'm making a big assumption that the majority are Mexican American in LA, but if you want to transfer this to the rest of the country, to distinguish between the different types of Latino.
Yeah, so historically, DMH in LA, they've had this huge issue where they have clumped together individuals who identify as either, either foreign-born or biracial or, from mixed ethnicities or racial backgrounds. And it's hard at this point because of the survey tools that they've been using for the past several decades. It creates this very deceiving, homogenous group of folks. But moving forward, what most folks don't know about is that DMH is actually comprised of a very young leadership team currently. I think the oldest member on the leadership team has actually only been there for about a year and a half. And so they're really trying to push forward this notion of creating these tools where they can break down how they identify as far as like Latino, like specifically, like is there a country of origin? And also not just that, but also comprising like the cultural and linguistic capability of that person. So to really give more of a multifaceted profile of where these patients are coming from. Mm-hmm. Thank you.
Amazing. Wow. Let's just give a hand to all the fellows. I'm blown away by this work, and so I'm really excited and really going to keep track and see how this progresses and how your career progresses. I just wanted to spend just a brief amount of time just showing how the work that you're doing connects with some of the work that's come out at the fund, and you may have seen these in your literature searches. And so with Dr. Parker's work, we had a piece in the fund talking about a connected patient is a healthier patient. And so your work really signifies and shows the importance of that connection and really creating digital tools to do that. And I really want to just highlight just bringing your perspective as an oncologist to these spaces allows them to think more about oncology. And so that out-of-the-box thinking is really what's needed. When Dr. Lipa's work around Medicare Accountable Care Organizations, the ACOs, there was some work that came out showing that ACOs that serve a high proportion of racial and ethnic minorities actually perform worse on some measures. And so it'd be interesting if you're able to sort of shift out some of the data on percentage of minority patients in the ACOs. It'll be interesting to just get a sense of how that has an impact. But again, it's really important to think through issues facing patients of color, which include thinking about musculoskeletal and spinal fractures and whatnot. And so really excited about the work that you're doing. The public charge is a huge issue, and a lot has come out on the fund about that, and I want to talk more about the email. Maybe we should think about preparing some work as well to think through how to provide information to the public and to our audience so that we can ensure that it doesn't impact coverage. And again, this work just confirms what Dr. Amenadian had mentioned about just the dramatic impact on coverage and healthcare access to thousands in communities. And with Dr. Hervé McGee. And it's interesting because my name has an accent aigu also, so I need to start including it. But your work was just really profound. And even with the SUPPORT Act that came, which was legislation signed by the president, on substance use disorder prevention and to promote opioid recovery and treatment in patients. But that act really includes mandatory coverage of medication-assisted treatment and additional enhanced functions to provide and address substance use disorder health homes. And so, so the work that you're doing, it's really important to highlight, in addition to this work, that we've put out through the fund, to really just provide some additional information on the differences in this treatment and how we really need to ensure that we're talking about the right thing. And Dr. Gonzalez, we talked a little bit yesterday about your work around behavioral health inequities among the Latino population, and it's really, we're doing a lot of work around integration of primary health care and integration of specialties, particularly mental health. And so you really highlighted just the importance of those models. And there's several people that we're working with that you should definitely talk to as well as you move forward in this work. And so I want to just end really with this primary health care strategy that one of the strategies we're moving forth through at the fund. And when I say primary health care, specialists don't go to sleep. But really we had recently gone to Cuba to understand how they're able to do primary health care so well. And having primary care as a foundation makes our job easier as specialists. And sort of as an OBGYN, I'm sort of a specialist and a primary care doc combination, but it's really important. And really, primary care doctors can't go it alone. I think we have the sense in our society that primary care doctors should do everything. And the challenge that I've always had is when I'm working in underserved communities, if you just focus on primary care clinicians, and you alluded to this in your work, then they're not having access to the specialty services that they need. And there's only so much that one provider can do. And so really we're defining primary health care as multidisciplinary teams, including the community, integration of primary health care with specialists, public health, social services, incorporating social determinants of health and behavioral health, thinking through mobile and digital health technologies, which touches on Dr. Parker's work, thinking about the patient and proactive engagement as well, and the active use of data, which all of you have shown. It's really important to understand that data to be able to show policymakers or whoever your audiences are where the disparities, what are the challenges, and how to address them. And I think medical homes are foundations, but really thinking through this broad vision where there's integrated care is critical. And how are we moving this work forward? We're thinking through affecting change through community-level processes and payment-level processes and frontline interventions, which all of your work has touched. And also with payment and policy, thinking of the regulatory market, the payers, with community-led processes. And we heard a lot about that yesterday in the community panel on the maternal disparities work that was presented, really the importance of communities, and really they're the front line, provide people on the ground that connect connect patients to health systems, and also frontline interventions that include the healthcare systems. And all of that ultimately is to improve care for the patient. And so really, I just wanted to thank you for all of your work, and please stay connected to our work at the fund. Even with as your work gets published, we'd love to highlight it, and we'd love to have you write blogs or issue briefs, etc. Just really to get this work out there to a broad audience. I think that's really very important. So I'll stop there, and we'll see if others have questions for the rest of you. Are we out of time? Oh, okay. Okay. Oh no. Okay. We missed his question. So just come up to the front and talk to the fellows for their questions. You want to close that? Okay, great. I think we started a little late.
Thank you for that commentary. As per usual, our fearless leader had to step out because she is traveling to go give another talk to spread the gospel of the good work that we are doing here and her great work in talking about leadership. So with that, we will conclude this morning session. There is lunch that is available, and in about 6 minutes, we'll be gearing up for the 10th annual Reed Scholars Annual Health Equity Symposium. So grab your lunch, converse, congratulate the fellows on their wonderful presentations, and we'll be right back here in a few minutes for our next panel.